Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 163 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, KJA, a 45-year female patient presents to your accident and emergency department with a severe headache and photophobia. KJA states that she was fine until yesterday, when she developed a fever and severe neck pain. She has a past medical history significant for hypertension. She has no known drug or food allergies. Some of her pertinent vitals include a body temperature of 38.8 degrees Celsius, a blood pressure of 142 systolic and 90 diastolic, and a heart rate of 100 beats per minute. On physical examination, the following are noted: nuchal rigidity, positive Koenig's sign, though there are no rashes. Her pertinent labs are remarkable only for an increased WBC of 15 times 10 power 3 cells per millimeter cubed. All other laboratory values are within normal limits. A lumbar puncture (LP) is done and the results are as follows: a WBC of 200 cells per millimeter cubed with 20% neutrophils and 70% lymphocytes, protein 80 mg per deciliter, and cerebrospinal fluid (CSF) to serum glucose ratio of 0.5. Blood, urine, and CSF are sent for culture and gram stain. Her head CT is negative. So my question to you is, in addition to dexamethasone therapy, which of the following is the best treatment option for KJA now? Is it A. ceftriaxone plus ampicillin plus vancomycin plus acyclovir, or B. ceftriaxone plus acyclovir plus vancomycin, or C. ceftriaxone plus ampicillin plus vancomycin, or is it D. ceftriaxone plus vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. ceftriaxone plus acyclovir plus vancomycin. This patient presents with community-acquired meningitis. However, the CSF findings are inconsistent with bacterial and viral meningitis, rather, they are consistent with a mixture of both. Although the WBC in the CSF is 200 cells per millimeter cubed and consistent with a viral cause, the count may actually be lower in early bacterial meningitis because of the acuity of the illness. The predominance of lymphocytes in the CSF indicates a potential viral cause, but the elevated protein concentrations suggest that bacteria are present. Finally, the CSF to serum glucose ratio is in between the ratio that would occur in viral meningitis, which should be 0.6, or bacterial meningitis, which is usually less than 0.4. Therefore, all the possible likely organisms should be covered in the treatment regimen. Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitidis, and viral are all potential causes. Therefore, answer B, a combination of vancomycin and ceftriaxone for the bacteria and acyclovir for possible herpes simplex virus type 1 HSV1, would be best. That makes answers A, C, and D incorrect. And the next question reads, Gram stain of the CSF reveals gram-negative diplococci, and a polymerase chain reaction, PCR of the CSF is negative for HSV, so my question to you is, which of the following would be the next best course of action in KJA's case? Would it be A. Discontinue vancomycin and ceftriaxone, continue acyclovir therapy, or B. Discontinue vancomycin and acyclovir, continue ceftriaxone therapy, or C. Discontinue vancomycin, continue ceftriaxone and acyclovir, or would it be D. Make no changes to the current therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Discontinue vancomycin and acyclovir, continue ceftriaxone therapy. The gram stain result is most likely Neisseria meningitidis, therefore, acyclovir and vancomycin should be discontinued. That makes answer B correct. Answers C and A are not the best because continuing acyclovir at this point is unwarranted. Answer D is not viable because, as stewards of antimicrobials, we must tailor the therapy at this point to remove gram-positive and viral coverage. Please advance to the next question. And the next question reads, BMA, a 36-year-old female patient was admitted to the hospital 2 days ago with suspected HSV1 encephalitis. Her pertinent vitals included a body temperature of 39.1 degrees Celsius on presentation, but it is now 38.2 degrees Celsius. CSF analysis results include normal opening pressure, a WBC of 5 cells per millimeter cubed with 98% lymphocytes, protein 45 mg per deciliter, and glucose 62 mg per deciliter. The PCR for HSV1 is reported negative. A head CT is done and it shows edema in the left temporal lobe. BMA is initiated on acyclovir 10 mg per kilogram IV thrice daily at the Accident and Emergency Department. So my question to you is, which of the following would be the best next step in the care of BMA? Would it be A. Increase acyclovir dosing to 20 mg per kilogram for 3 weeks without repeat PCR testing, or B. Repeat PCR testing tomorrow and continue acyclovir therapy for 14 days, or C. Repeat PCR testing tomorrow and discontinue acyclovir therapy, or would it be D. Discontinue acyclovir therapy because the PCR was negative? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Repeat PCR testing tomorrow and continue acyclovir therapy for 14 days. When a patient presents with a clinical syndrome and CT findings consistent with HSV1 infection but has a negative initial PCR, repeat testing should be done in 3 to 7 days. Therapy should continue in these patients to prevent relapse, morbidity, and mortality. Increasing the acyclovir dose to 20 mg per kilogram has shown benefits in neonates, but not adults. Therefore, answer B is best while answers A, C, and D are incorrect. Please move on to the next question. And the next question reads, BPA, a 34-year-old male patient with a height of 70 inches, and a weight of 75 kilograms presents to your accident and emergency department with a chief complaint of confusion and disorientation. He has a body temperature of 38.6 degrees Celsius. His pertinent labs are all within normal limits, including serum creatinine 0.8 mg per deciliter and a WBC of 6,800 cells per millimeter cubed. Toxicology screening turns negative. A head CT returns negative for hemorrhage, edema, and sinusitis. A lumbar puncture is done and it shows normal opening pressure, a WBC of 125 cells per millimeter cubed, with 99% lymphocytes, glucose 62 mg per deciliter and 130 mg per deciliter in the serum, and protein 70 mg per deciliter. A gram stain returns negative for bacteria. So my question to you is, which of the following would be the most appropriate empiric therapy for BPA now? Would it be A. Acyclovir 1500 mg IV twice daily, or B. Acyclovir 750 mg IV thrice daily, or C. Ceftriaxone 2 grams IV twice daily plus vancomycin 2 grams IV twice daily plus ampicillin 2 grams IV every 4 hours, or would it be D. Ceftriaxone 2 grams IV twice daily plus vancomycin 1500 mg IV twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And answer C is correct. Acyclovir 10 mg per kilogram IV thrice daily to treat viral encephalitis. The patient presented with signs and symptoms of viral encephalitis, and the lumbar puncture is most consistent with viral etiology. Because the gram stain is negative and the lumbar puncture is inconsistent with bacterial origin, answers D and C are incorrect. Answer A is incorrect because the 20 mg per kilogram dose is reserved for infants and children and should be administered every 8 hours instead of the 12-hour interval in this option. Please advance to the next question. And the next question reads, QPA, a 29-year-old female patient with a height of 65 inches, and a weight of 65 kilograms, presents to your accident and emergency department with a chief complaint of confusion and headache. Her body temperature is 39.1 degrees Celsius. Her lab values are all within normal limits and she has a serum creatinine of 0.7 mg per deciliter, but her WBC is 19 times 10 power 3 cells per millimeter cubed. Her head CT turns negative for hemorrhage, edema, and sinusitis. A lumbar puncture is done and it shows an elevated opening pressure. It has a WBC of 1250 cells per millimeter cubed with 99% neutrophils, glucose 20 mg per deciliter with 110 mg per deciliter in the serum, and protein 300 mg per deciliter. Her gram stain is still pending. So my question to you is, which of the following would be most appropriate regarding dexamethasone therapy for QPA now? Would it be A. Dexamethasone 10 mg IV 4 times daily should be administered 24 hours after initiating antibiotic therapy, or B. Dexamethasone 2.5 mg IV 4 times daily should be administered before antibiotic therapy, or C. Dexamethasone 10 mg IV 4 times daily should be administered before antibiotic therapy, or would it be D. Dexamethasone should not be considered because this appears to be viral encephalitis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Dexamethasone 10 mg IV 4 times daily should be administered before antibiotic therapy. Answer C is correct. The CSF findings of the lumbar puncture are consistent with bacterial meningitis, therefore, dexamethasone 10 mg intravenously every 6 hours should be administered immediately, or at least concomitantly with antibiotics, to prevent complications. That makes answers A, B, and D incorrect. Please advance to the next question. And the next question reads, which of the following suggested regimens of antimicrobial therapy would best be administered to QPA? Would it be A. Ceftriaxone 2 grams IV twice daily plus vancomycin 1250 mg IV twice daily plus ampicillin 2 grams IV every 4 hours, or would it be B. Ceftriaxone 2 grams IV twice daily plus vancomycin 1250 mg IV twice daily, or would it be C. Acyclovir 1300 mg per kilogram IV thrice daily, or would it be D. Acyclovir 650 mg per kilogram IV thrice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Ceftriaxone 2 grams IV twice daily plus vancomycin 1250 mg IV twice daily. Because the origin of this infection is likely bacterial, antibiotics, and not antivirals, should be administered, therefore, answers D and C are incorrect. Answer A is incorrect because there is no indication to administer ampicillin. It's not likely caused by Listeria monocytogenes. Therefore, answer B is the best choice. And the next question reads, which set of immunizations would you consider the most appropriate to administer to immunocompetent children 2 years and younger to prevent meningitis? Would it be A. Pneumococcal polysaccharide vaccine, PPSV23, HIV, meningococcal, and listeria, or B. Pneumococcal polysaccharide vaccine PPSV23, HIV, and meningococcal, or C. Pneumococcal conjugate vaccine, PCV13, Hib, and meningococcal, or would it be D. Pneumococcal conjugate vaccine, PCV13, and Haemophilus influenza type B vaccine HIV? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Pneumococcal conjugate vaccine, PCV13, and Haemophilus influenza type B vaccine HIB. Answer D is correct because the PCV13 and Haemophilus influenza type B vaccine HIB vaccines are recommended in children 2 years and younger. The meningococcal vaccine is only recommended in children with asplenia, HIV, or complement deficiency. That makes answers A to C incorrect. There is currently no vaccine for listeria. That makes answer A incorrect. Please advance to the next question. And the next question reads, JWA, a 27-year-old female patient is admitted to the neurological ICU after motor vehicle accident in which she had a traumatic penetrating brain injury. On day 3, she begins spiking fevers with a body temperature of 39.3 degrees Celsius, and having seizures. Her MRI brain shows ventriculitis. CSF analysis results are as follows: a WBC 2000 cells per millimeter cubed with 98% neutrophils, glucose 25 mg per deciliter with 150 mg per deciliter in the serum, and protein 350 mg per deciliter. Per gram stain is still pending. So my question to you is, which of the following regimens would be the most appropriate antimicrobial regimen to initiate in JWA's case? Would it be A. Cefepime plus ampicillin plus vancomycin, or B. Cefepime plus vancomycin, or C. Ceftriaxone plus ampicillin plus vancomycin, or would it be D. Ceftriaxone plus vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Cefepime plus vancomycin. Because this is healthcare-associated meningitis or ventriculitis, we need to be concerned with organisms such as Staphylococcus aureus and Pseudomonas aeruginosa, therefore, answers D and C are incorrect. Answer A is incorrect because there is little concern for Listeria monocytogenes in healthcare-associated meningitis. Therefore, answer B is correct. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 164.